we would have been somewhere in the USA doing some computer applications or other work, and we are lucky to have you as a neurosurgeon in our faculty in India, in PGI, and the number of aneurysm surgery that you have done, that is really remarkable, and we are sure that we will not have something from you.
Sandeep, you can start.
Yes, sir.
You can share your slides also.
Yes, sir. Yes, sir. So, thank you very much. Thank you, IMA Kanpur, and especially to Dr. Jayant Verma, who is my mentor and teacher. It is only because of him that I joined neurosurgery. I was a junior resident, general surgery resident during my PGI days, when Dr. Jayant Verma picked me up as one of his favorite resident to assist him in surgeries during emergency surgery days. So that is why I was so much influenced by Dr. Jayant. His skills, his decision making, his quickness, and his hard work, sheer commitment to get the things right. The way he used to manage small knitting integrities issues, managerial skills, nursing staff, and everything, that I was so influenced by him. So that is why I joined neurosurgery after him. He finished his residency and pushed me inside for my neurosurgical career. Thank you very much, Dr. Jayant. Thank you very much that I'm here today. I'll start with the PowerPoint presentation. We'll be discussing just am I audible to everybody?
Yes.
Yes. Okay. So we'll be discussing something about intracranial neoplasm. It's a overall generalized presentation regarding spectrum and what people think, what other fellows are medical fellows think about neoplasms, how they fare, what are they, how serious it is, and what are the managerial skills required and management techniques which have evolved over time. This is just a small video which is playing besides it. It just shows a normal brain, how beautiful it is. This video was recording during my residency days when I was so much influenced to see this live brain pulsating under microscope. So what are the demographics? Usually the male and female predisposition for intracranial neoplasm is almost same. It's around 53:47. Pediatrics, 16% of the patients belong to children. Astrocytomas, embryonal, embedemal tumors are the predominant pediatric tumors. Adults, yes, significant. 4 out of every 5 tumors belong to adults. These are meningiomas, glioblastomas, and nerve sheath tumors. Age distribution is also in a typical, not typical of bimodal, but it's almost like that. From 0 to 10, there are significant number of pediatric tumors which are in that age group 0 to 10, and then it suddenly shifts to 40 to 49 age group. Then the distribution of neoplasms is maximally reported in 4th decade of life. Histologically distribution, so it's not all that bad. 1 out of every 5, that is 20% of the tumors are meningiomas only. These are benign lesions. Next one is the most malignant one. These are glioblastomas. This is around 14% of the tumors. Others can be nerve sheath, embryonal, oligocentric, craniopharyngiomas, lymphomas, glioneural tumors, pineal tumors, choroid plexus tumors, germ cell tumors. In pediatrics, astrocytoma takes the cake. It's 1 out of every 5, 1 out of every 4 rather. It's 25% tumors are just pediatrics. It's just astrocytoma. These are benign lesions. So nothing to worry about these tumors. This is the most favorable histology which we get from children. So this is the distribution. These are the leading institutes, neurosurgical centers over India: AIMS, NIMHANS, PGIMR, CMC Vellore, Pant, Among all these institutes, the more or less it is the same predisposition what we have discussed. This is the distribution of the neoplasms reported by different institutes till date. Not a significant change. It is more or less in correlation with the international numbers. So what are the usual presentations of brain tumors? So this is specifically for our fellow medicos, the people who belong to other branches. So what is the thing which make us alert about it? Headache, with or without vomitings. Either way, headache should be taken seriously. Seizures, obviously, it's a cortical irritation which lead on to the formation of the formation of seizures, and which is a serious presentation and should always be investigated. Focal deficit like monoparesis or hemiparesis, any deficit if a patient has developed and it's a new onset, should be taken seriously. Vision loss, yes, unilateral or bilateral. If a patient complains of vision loss, there is some haziness, it should always be viewed with suspicion. Cranial nerve deficits, new formed cranial deficits like swallowing reflex and the cavernous sinus syndromes, these are all serious things, should always be investigated with the dedicated imaging. Among children, this is a strange presentation like increasing head size because of open fontanella like choroid plexus papilloma. These tumors present like this. So this is a flow diagram which we made some around 5 years back when AIIMS had invited us, that how the brain tumors should reach the tertiary care institutes with the complete flow. Just look at this slide. At primary health center, our 80% of the population reaches the primary health center first. Presentation is seizures. Every patient with seizures presenting at PHC should be investigated with serum sodium and blood sugar. Headache and vomiting or focal neurological deficit, vision loss or cranial nerve deficits, they all should be investigated with serum sodium and blood sugar. If there is a seizure, then phenotization should be done at PHC level, airway protection, and then the patient reaches district hospital. The government of India claims that each and every district hospital of India is equipped with a CT scan. So yes, CT scan is mandatory at every district hospital, and the patient should reach district hospital and CT scan should be there if any of these symptoms are there. So once the CT scan is now positive, then the patient reaches the medical college or cancer hospital for MRI scan. If it is negative, then the medical management starts there and then only for epilepsy. So now if in medical college, cancer hospital, the patient has got MRI and there is a lesion and patient requires surgery, if it is possible, it is done over there. If no surgery is warranted at that particular stage of the neoplasm, follow-up is required, then the patient continues to shuffle with medical college from his home to medical college. If the patient requires surgery, if it is done, good, well and good. If not done, then the patient reaches the tertiary care centers like PGI and AIIMS Medical Institute. Then it is performed over there. Radiosurgery is usually not available readily at most of the places. So it depends upon the medical institute how to provide the radiosurgery facilities to that patient. So this is the flow diagram, like how the patient should proceed, and each and every patient with seizures or a suspected neoplasm should be investigated at district hospital with a CT scan, and if it is positive, should be mobilized at the earliest to the medical institute where the surgical facilities can be made available. So as we have discussed, general signs and symptoms are the same. Progressive neurological deficit, which is present in about 66% of the patients, which is usually motor weakness. Headache presenting in almost half of the patients is there. Seizures are present in 25% of the patients, and it can be focal or leading on to secondary generalization. So what our book describes, this is a statement taken from the classical Rangachari book of neurosurgery and is now given even in Harrison's. Headache is classically described as being worse in the morning, possibly due to hypoventilation during sleep, exaggerated by the coughing, straining, and bending forward, which is associated with nausea and vomiting in 40% and may be temporarily relieved by vomiting due to hyperventilation, which is usually associated with vomiting, along with the presence of a focal neurological deficit. This is the classical presentation of an intracranial mass lesion. We divide the intracranial neoplasms into two subgroups: pediatric brain tumors and adult brain tumors. In pediatrics, gliomas take the major chunk. These are pilocytic astrocytomas usually. Gliomas, cerebellum, commonest site, brainstem, and then optic nerve. Second is the malignant one, PNET or medulloblastomas, which is nowadays having a good prognosis because of the better adjuvant therapies. Third one is craniopharyngiomas. Fourth is pineal tumors, or the fifth one is teratomas. The percentage distribution of tumors is as given below. So pilocytic astrocytomas, what are these? This is classified WHO grade 1. Pilocytic astrocytomas are low-grade astrocytomas successfully resected in posterior fossa, provides the children with the normal life as we, you, and everyone. This should be very clearly differentiated from other astrocytomas or from the malignant tumors of the pediatrics, and should be seen and picked up as quickly as possible because these are curable lesions. This is a subgroup of astrocytomas grade 1. Better prognosis, 10-year survival is more than 95%. Then infiltrating the other diffuse astrocytomas. Most common gliomas in pediatrics is this one. Incidence progressively declines after age of 15. Slight male predilection is there, but not significant. Location. Cerebellum takes the cakewalk. Cerebellum and cerebral hemispheres, they make around 70% of the location sites. Third one is tricky, optic gliomas and hypothalamic gliomas. This location itself makes these lesions as biologically malignant. I'll talk about it later on. Brainstem pilocytic astrocytomas, these are again of two types. One is diffuse, one is exophytic, and the fifth one is spinal cord. We'll not discuss that. The genetic abnormality in these tumors, which activates this pathway in cerebellar, causes pilocytic astrocytomas. These are all pathological things. Pathology is the hallmark, low to moderate cellularity, cells with long, thin bipolar processes, defined as rosenthal fibers, loosely knit tissue comprising stellate astrocytes with microcytes. Now, the treatment, complete surgical resection when possible, is usually curative. Here comes the role of a good neurosurgery. For cystic pilocytic astrocytoma with enhancing moral nodule, only the nodules needs to be resected. Walls need not to be fiddled with, and post-operatively, usually nothing is required in these patients once the lesion is excised. Now, I'll show you some of the example. As I am aware that our fellows are non-neurosurgical, so I have tried to take the things to their levels to my best. This is an example of a pilocytic astrocytoma. This is a variegated lesion with cystic yellow color, kind of a yellow colored fluid is there in these lesions. And this is the sagittal section of the same patient. See the balloons, small balloons, congregate lesions with this fluid accumulated within the multiple cysts, pushing the brainstem as well as the cerebellum upwards. Now, this is the contrast image, sagittal image of the same patient. Now, see the pilocytic astrocytoma, how nicely it has occupied almost the complete fourth ventricle and is compressing the brainstem. Now, this lesion is excised successfully surgically, and this is the 10 years post-operatively MRI of this child. There is no lesion. Child is absolutely fine. So we move on to the next category now. These are medulloblastomas. These are suddenly placed into WHO grade 4. These are small cell embryonal grade 4 tumors in posterior fossa, peaking during first decade of life. This is commonest pediatric malignancy, and these are classified as malignant lesions. These usually arise in the cerebellar vermis near the apex of the fourth ventricle and or in the posterior brainstem, often producing hydrocephalus. Hydrocephalus is commonly associated with these lesions. So medulloblastomas recently have got a flip in their classification of pathology, because of which now classical, desmoblastic, extensive nodularity, large cell anaplastic, these varieties have been labeled up. This labeling has improved their prognostication value by significant effect. Classical and desmoblastic medulloblastomas are almost curable nowadays with nice, good surgical excision followed by chemotherapy. The third and fourth variety have got poorer prognosis. So what is the management of medulloblastoma? Once a child has come up with a medulloblastoma and diagnosis is there with medulloblastoma, there is nothing like nihilistic attitude for these children. First, preoperative shunting. In PGI Chandigarh, we do preoperative shunting in medulloblastoma in almost all patients in which equivocal hydrocephalus is there. Surgical debulking of as much as tumor is possible without causing neurological injury to obtain tissue for classification and decreasing the cellular burden. It improves the outcome. Post-operative shunt may or may not be required for the patients who have not been shunted earlier. Shunt-related seedlings have been reported, but it is under doubt. So this is the risk stratification done post-operatively based on the histological profile, as I have discussed earlier. These are the first one is the low risk standard group of medulloblastomas in which adjuvant therapy, radiotherapy, chemotherapy, and conventional radiotherapy to the craniospinal axis after good surgical excision provides us the cure. High risk patients, in those patients, conventional fractionated radiotherapy is given to the site as well as to the craniospinal axis. Chemotherapeutic agents are still in vogue. They are being used in almost all patients. Adults, which are different, these are mutations and much more responsive to the receptors, and new drugs are into the vogue for adult medulloblastomas. To make the things more interesting, and our fellows, radiology imaging people must be there. They must be enjoying this radiology. This is a classical medulloblastoma contrast enhancing image, a lesion sitting exactly in the midline, pushing both the cerebellar hemispheres and the brainstem, occupying almost whole of the fourth ventricle, and the vermis has been pushed up. This is a classical medulloblastoma in which the lesion variegated appearance, no cyst, intermittent contrast enhancement. This is the surgical procedure which is performed for these patients. This is our classical prone position to expose the suboccipital craniotomy and craniectomy, whatever we decide. Inside is this this is the image taken. This is the incision which has been marked, and this is the position which is made. So now the incision has been given. You can see this is the cranial end, this is the caudal end, this is the bone which has been marked, this is the atlas which has been exposed, this is the superior nuchal line. This craniotomy has been done. This is the transverse sinus on which the gel form has been placed, and this is the foramen magnum. This dura has been exposed. Now the dura has been opened, and these are the veins. This is the cerebellar surface. Dura has been hitched on both the sides. These are the tonsils. These are the tonsils. This is the fourth ventricle outflow. Just enjoy this video. This is the suboccipital craniotomy made where the arachnoid is visible. Pulsating CSF is coming out from the fourth ventricle. This is the cranial end. This is the caudal end. Dura has been hitched. This is the medulla oblongata. This is the pica. This is the pica vessel, which is segment 4, which is entering into the fourth ventricle. This is the vermis of the cerebellum, underneath which lies the tumor. These are the cerebellar hemispheres, both the sides. This approach to the medulloblastoma is after splitting this or lifting these tonsils up, what we call telovelar approach. This pica is called the segment 4, which enters the fourth ventricle, which is visible. This is the vermis which has been split, and this tumor is being taken out. This grayish is the tumor which is being taken out. This is the tumor. The medulloblastoma is being taken out. This is the bipolar forceps which we are using. In almost all cases of medulloblastomas, the patients are shunted preoperatively. That is why the cerebellum is made lax, and you can see this is the bipolar forceps, and the irrigation with the irrigation fluid of Norman's line is being used. Vermis has been split. This medulloblastoma has been exposed. This is the medulloblastoma which has been exposed. We have exposed this thing after splitting the vermis. Vermis was here, which has been split. So we use the bipolar forceps to take out the tumor underneath from underneath the cerebellar surface. We are trying to reach till the floor of the fourth ventricle to expose the brainstem. I'll show you after the removal of this tumor, the whole brainstem is made bare. We can see the floor of the fourth ventricle. This is the tumor which has been lifted up. Now, the whole tumor has been taken out, and we are now checking the excision of our medulloblastoma. As I had explained, this is pica, posterior inferior cerebellar artery of segment 4, which is entering into the fourth ventricle. This is the tonsil of the cerebellum, which has been lifted up. And now here we expose the brainstem. This is the brainstem. This is medulla oblongata. This one is medulla oblongata. Yes. Now we have just lifted little bit the cerebellar tonsil to expose the fourth ventricle. This is a beautifully placed floor of fourth ventricle. What we read in our neuroanatomy books during our first year MBBS, we'll zoom it and we'll show you the yes. This is the floor of fourth ventricle. What the diagram which we used to make of rhomboids and horizontally placed stria medullaris. This is the stria medullaris. Just see this. Just see this thing. This is stria medullaris. These are the triangles which are visible after these successful excision of medulloblastomas. This is the fourth ventricle. We are seeing inside the fourth ventricle. So this is the brainstem. This whole is the brainstem. This is the stria. And these are the triangles underneath the stria, both above and below the stria. So this is the same video from which I have taken out this image to label it the diagram from the book of neuroanatomy first year MBBS. The same diagram is visible intraoperatively. And this aqueduct shows the free egress of CSF, proving that the outlet has been unobstructed and CSF free release has been there. We operate posterior fossa tumors sitting at the cranial end. We are sitting at the cranial end ourselves. So this is the post-operative scan of this patient. So medulloblastomas. This is an example. This is again example of medulloblastoma. This is T2 weighted scan. The previous one was T1 weighted scan. This is again the contrast enhancing sagittals image 7 years after the surgery. This is no lesion and the patient is completely cured now. What are we move on to the next category, that is craniopharyngiomas. These are benign partially cystic epithelial tumor of Sellar's region. They are basically pathologically benign lesions located at a very stringent place, that is Sellar's suprasellar region. And the usual features are raised intracranial pressure, papilledema, and visual symptoms like decreasing visual acuity or bitemporal hemianopia. So this is the different types of classification according to surgery which has been made: prefundibular, transfundibular, or retroinfundibular. This is another classification by Sargil regarding the invasion of the diaphragm and reaching up to the third ventricle. So this is our approach. This is published by PJ Chandigarh regarding the management of craniopharyngiomas and how should we plan about the differentiation between endoscopic or transcranial route, how to differentiate and how to decide. Now, I'll carry on my aim to make the things interesting. This is a craniopharyngioma. Just see how large a lesion is occupying cellar, suprasellar, and third ventricular region. This lesion was operated through a transcranial route. 7 years after surgery, this is the MRI of this patient. Another lesion is optic pathway hypothalamic gliomas. These are very rare lesions, but still we face these lesions. 3 to 5% of childhood brain tumors, 70% are less than 10 years, and 90% are less than 20 years. So once the child crosses the age of 20 to 25 years of age, then these lesions become silent. These are also called optic chiasmatic hypothalamic gliomas or pure optic nerve gliomas. These are pathologically grade 1 only, but still their location makes them very stringent, and excision becomes very difficult. There is no sex predilection. Both males and females are equally affected. And treatment options is very strange. You can have sometimes even only conservative. You just wait and watch. Second option can only be biopsy and just wait and watch. Third can be chemotherapy only after biopsy and wait and watch. Radical surgical excision is quite unlikely for these cases because of huge neurological deficits which we can incur, because these are finally benign gliomas only. Interesting case, choroid plexus papilloma. This is one of our favorite. Just see this lesion. It's a beautiful frond-like appearance lesion sitting in the temporal horn of a baby with a hydrocephalus and 3 years post-op. Nice MRI. There's no lesion left. This is a benign lesion. Now I move on to the adult neoplasm, gliomas. Diffuse interesting intrinsic gliomas, glioblastomas, classified according to grade 1, 2, 3, 4. 1 is usually not found in adults. It's only 2, 3, 4 which are predominant among adult populations. Meningiomas number 2, pituitary tumors, schwannomas, malignant lesions like mesenchymal sarcomas, hemangioparasitomas, or blastomas. Last one is choroid plexus tumors, but these are quite rare among adult population. Now we move on to the gliomas as classical tumors, astrocytic tumors. These are commonest primary intraaxial tumor among adults. Diffuse gliomas like grade 2, this is and other astrocytic tumors. Diffuse gliomas are grade 2 to 3 astrocytic tumors, grade 2 to 3 oligodendrogliomas, grade 4 are glioblastomas with very bad prognosis. This is the recent classification of gliomas, which keeps on changing every 2 to 3 years because of the molecular biology which is coming up and is changing the prognostication of each and every gliomas very rapidly. And that is why the changes in the adjuvant therapies in the form of chemotherapy is coming up. So diffuse astrocytomas, which is grade 2. Grade 1 I have omitted. Grade 1 we had already talked among the children. Grade 2. Grade 2 have got predilection for temporal, posterior frontal, or parietal lobes. Histology is low degrees of cellularity with highly differentiated cells, preservation of normal brain elements within the tumor, calcifications are rare, mitosis is absent. Typical imaging is there. T1, W1 MRI is hypointense, shows high intensity changes on T2, and a median survival of quite good duration is there. It's around 11 years. This is a bad tumor, anaplastic astrocytoma, grade 3. This is diffuse infiltrating astrocytomas with diffuse interspersed anaplasia. Molecular genetics is also positive. Radiology shows complex enhancement on CT and MRI and is very ill-defined. Ring enhancement is typical of glioblastoma. It is not seen in type 3, but still it can occur. Now this last one is new variety which has come up. IDH wild type diffuse astrocytomas which has come up. It behaves very aggressively than IDH mutant and almost like glioblastomas. Now, what is glioblastoma? This tumor will not let neurosurgeons sit at ease. The moment this diagnosis is there, we are tied. We almost have no reply, no answer to the queries posed by these patients harboring glioblastomas. This is commonest astrocytoma, the most lethal. The term glioblastoma multiforme is absolute, but still it is being used as a common abbreviation. There are 3 main types: GBM classical, IDH wild, IDH mutant, and not otherwise specified. Primary glioblastomas, majority of GBMs arise without evidence or of a less malignant precursor, more common in older patients. Usually patients are more than around 60 years of age with very short clinical history, and in spite of doing anything, we don't have any reply for these gliomas. Secondary glioblastomas have also been reported. We also see at our institute arise from malignant degeneration of WHO grade 2 or 3. That means these patients had earlier got surgery for the astrocytomas, which was grade 2 or 3. Now they have got recurrence. And when we operate, this time their biopsy becomes grade 4, that is glioblastomas. These patients are younger, slower clinical course. Imaging is very classical. Large central necrosis, ring enhancing, IDH mutants are there. Mostly these are located in temporal, parietal, frontal, occipital. Now, what is the treatment for these cases? Maximal safe resection with radiotherapy and chemotherapy is what is being advocated, advised, followed across the globe with a lifespan not more than 9 to 12 months. Glioblastoma, once the diagnosis is established, in spite of all three therapies, the lifespan remains the same. I'll shift on to the better, more surgeon and patient friendly tumors now, that is meningiomas. Commonest primary intracranial tumors and is around 1/3 of the total CNS tumors. These are usually slow growing, circumscribed. These arise from the meninges and then compress the brain. They are not inherently occurring within the brain parenchyma. They are usually slow growing. Locations: parasagittal, convexity, tuberculum cellae or spinatal, olfactory groove. These are different locations which are there. Meningiomas have also been graded by the WHO again into 1, 2, and 3. Mostly these are grade 1 tumors. Successfully excised, these tumors give us good lifespan. The treatment of choice is radical, good surgical excision along with the attachment at the dura. But still, grade 2 and 3 tend to recur, and radiotherapy is advised in these cases of grade 2 and 3. Shift on to the vestibular schwannomas. One of the most favorite among the microscopic neurosurgeons. Vestibular schwannomas test the surgical skill of the neurosurgeons under microscope. These are benign tumor of the 8th nerve located in CP angle, arising from the inferior division of vestibular nerve. And our neurology colleagues or medicine colleagues, they must be knowing about this clinical triad of hearing loss, which is insidious and progressive, tinnitus, which is high pitched, and disequilibrium. True vertigo is not there, but disequilibrium during walking is there. It's a classical triad which takes us to the diagnosis at the 8th cranial nerve. Workup is required, the same we all know. These are the acoustic tumors. Now, management options. Surprisingly, acoustic tumors do not warrant surgery every time. The diagnosis should not panic both the clinicians or the medical officers sitting at the periphery to make these patients run to the neurosurgeons. There is an option called observation for these patients. Second one is surgery. Third, new upcoming radiosurgery. That is what we call gamma knife. Now, the management options depend mainly upon how do we decide? Tumor size, how big is the tumor? Growth, how rapidly it is growing? Hearing status, is it a serviceable hearing loss with the patient or not? What is the 7th nerve function of these patients? Is already 7th nerve involved or not? Last one is this, NF2, is the patient harboring NF2 gene or not? All these factors will decide what options suit these patients the best. So these are the koos grading of the acoustic tumors. This is depending upon the size of the tumor. This grading has been established. In India, most of the patients land up with koos grade 3 or 4, mostly 4, because of their massive size of these tumors. In Europe or in America, these patients come at a very early stage because of their screening part available, those facilities available in the district hospitals. But here, the patients come very late. They come in grade 3 or 4, where we don't have any option for management options of observation or radiosurgery. Surgery is required. I'll move on to the next. Just enjoy this positioning of a CP angle tumor. For an acoustic tumor, how do we fix the patient? This is the 4-pin. For the people who are not neurosurgical, this is the 4-pin in which the head is fixed. This is this 4-pin associated with the fixed with the table. This is Mizuho's table, Japanese Mizuho's table, on which a patient is fixed. These are the supports which are fixed because this table is rotated right and left while excising these tumors. This is an example, MRI. MRI of a acoustic tumor. Left side giant acoustic tumor is visible. This is the previous one was T1 weighted scan. This was is the gadolinium enhanced scan of a large acoustic tumor. This is the T2 weighted scan. Just see how massive the tumor is and how badly the brainstem has been compressed by this tumor. This is the brainstem. This is the basilar artery. This is the medulla oblongata or pons, what we call, and how badly it has been compressed. This is the fourth ventricle, which is now just a slit. And this is the petrous bone which has been eroded, and this tumor has reached up till here. The whole petrous bone, this is the intracranial part, which has expanded massively along with the intracranial part. Now, this patient, 3 years post-op, this is the MRI scan. Successfully excised surgery, excised tumor, and this is the T2 weighted scan. This gives the best possible results for these patients. So after this is the same patient which we made ambulatory during our this is the same patient, the video of the patient just after excising the tumor. This is the 5th day. The patient started walking with support. This is the example, another example of right-sided acoustic tumor. This is the ice cream cone appearance of this tumor. Our radiology friends are very fond of describing these tumors as ice cream cone appearance. This is the basilar artery. Now, 10 years post-op, the same patient. Follow-up MRI, there's no tumor, nicely excised with the preservation of the 7th nerve. This is the lady. This is the 7th nerve preservation of this patient. Pituitary adenomas. These are again adenomas. These adenomas arise from the anterior pituitary. These are from adenophysis. These are benign lesions. Their presentation can be excess hormone secretion, hyperprolactinoma, Cushing syndrome, acromegaly, or they can have mass effect leading on to bitemporal hemianopia, or they can be just an incidental finding, or they can just present with an ictus. That is what we call as pituitary apoplexy. Treatment: prolactinoma, medical therapy only. For other tumors, this is transsphenoidal or transcranial. Post-op concerns include diabetes insipidus, adrenal insufficiency, or CSF leak, which is very common. So this is an example of bitemporal hemianopia. The patients present to us with these visual field chartings from ophthalmology department with the diagnosis of cellular supracellular lesions. This is classical bitemporal hemianopia. Now see, this patient, bitemporal hemianopia, diagnosed with MRI like this. This is the lesion sitting over there. This is the preoperative. Just see the chiasma, how it has been compressed. This is the internal carotid artery bilateral. This is the chiasma, which has been compressed from the tumor underneath. This is the postoperative scan. Just see, this is the normal pituitary gland, and this is the hypothalamic stalk. Same lesion. This is the chiasma, and this is the whole has been made lax, bilateral internal carotid artery. Again, this is an example of pituitary apoplexy, in which again the patient has come with bitemporal hemianopia along with this MRI. Now there's a huge mass lesion with hypodensity in between, with the ring contrast enhancement. And how do we come to know that it is apoplexy? because of the history of ictus. Yes, just see this MRI. MRI has got a fluid level. Just see this fluid level. This fluid level made us the diagnosis of apoplexy. Transphenoidal surgery done for this patient, and see the hypothalamic stalk and the whole tumor. This is the hypothalamic stalk, and the whole tumor has been excised. I'll move on to the interesting tumor, that is fourth ventricular ependymoma. This is another. Just see this variegated malignant lesion in the fourth ventricle, which is compressing the brainstem not from behind, from interiorly also. This is the lesion. From anteriorly as well as posteriorly, the whole brainstem has been compressed. Now, this patient post-operatively after 2 years, this is a stable lesion after surgery and radiotherapy, and the patient is just stable. We'll just carry on with the follow-up within these patients. Now, let me show you one surprise in neuro-oncology. Neuro-oncology is also gives us on and off surprise, and most of the times it is by the pathology department who give us the odd and off strange radiology, the pathology reports. But sometimes we also see these surprises at our own in the operation theaters itself. This is the CT scan with almost a calcified lesion. This is a plain CT scan with this rock lesion. And this is the MRI. This is the MRI T2 weighted scan. I don't know, any radiologist sitting over here can make out what it can turn out to be. This is a jet black lesion in a T2 weighted scan, showing intense heavy metal deposition within this tumor. This turned out to be melanoma. And this is the post-operative scan of the same patient. This is melanoma. I think I'll skip this video. This is an example of meningioma sitting in the skull base, anterior skull base lesion. This is a clinoidal meningioma. This is one of the most challenging surgeries at the cellular supracellular lesion. Just see this lesion. In this lesion, this is the ICA bifurcation, internal carotid artery getting bifurcated within the tumor. In this case, this is the sagittal image and 5 years post-op of this patient. No deficit with the patient. What is gamma knife neuroradiosurgery? This was a request by sir also, that gamma knife radiosurgery is a modality, and everybody wants to know that what it is and how this thing helps us in managing the neuro-oncology cases without incision, without blood loss, without the patient going into the operation theaters. This is our gamma knife center in PGI Chandigarh. What we do with this actually? This is the gamma knife surgery suite in which the patient is placed. And what is our understanding of gamma knife? How does it work? How it is different from conventional radiotherapy? When its role come into the picture? How the protocol of management is decided? And once the radiotherapy, that means radiosurgery, that is gamma knife has been given, monitoring of the patient and follow-up has to be done. Reduce the administration through the intact skull. Now, this is the definition of a gamma knife. The administration through the intact skull, the patient's skull remain intact. We do not make any hole, any craniotomy, any opening. It's a unique way. High dose of ionizing radiations are given in a very small intracranial volume located in critical areas, developed by Lexel neurosurgeon. This is called a gamma knife basically. So now, precise focusing of multiple beams of low energy. This is the basic. Just see this, look at this image. This lesion is located over here. High dose is made available at the target volume, and there is sharp fallout the moment that lesion is moved out. That is the beauty of gamma knife. That means the exact lesion will get a very heavy, large dose of ionizing radiation at that particular area without injuring or damaging any neuronal structures associated with it or just along with it. That is the major function of gamma knife. Gamma knife can only be given for the patients in which the granuloma, this is not indicated. So why gamma knife radiosurgery is called gamma knife radiosurgery? Gamma because it uses gamma rays, knife because the results are mostly comparable to the knife. That is the reason. And surgeons have an upper hand. Neurosurgeons all over the world use gamma knife radiosurgery. It is not the radiotherapists which are using radiosurgery because it's finally a radiation tool being used by the radiosurgeon. So this is the frame which is used. This is the Lexel frame which is available to us. 4 pins are planted on the patient's head and then head is fixed. Patient is taken into the gamma knife machine where 16 collimeters are fixed across the head of the patient. And the ionizing radiations are given just at that particular focus. In 1990s, when gamma knife was invented, at that time the indications were these: vascular malformations, vestibular schwannomas, residual meningiomas, glomus tumors, pituitary adenomas, or trigeminal neuralgia. Today, cavernous malformations, gliomas, metastasis, movement disorders, even psychosurgery like OCD, hypothalamic hematomas, or rarely epidermoid have become one of the indications. When do we treat? When do we say that gamma knife is required? It is because the functional outcome appears to be better with gamma knife. Neurosurgery is indicated when there is huge amount of mass effect. Gamma knife will not decrease the tumor load immediately. It is only indicated gamma knife when there is no mass effect and no potential growth and the preservation of facial nerve is there. When there is massive mass effect to the surrounding neuronal structures, there is intense edema to the surrounding neuronal structures like in brainstem, ventricles are compressed, then gamma knife is not indicated. For example, in acoustic tumors, tumors less than 3 centimeters in maximum diameters are considered to be the indications for the gamma knife. More than 3 centimeter acoustic tumors are not indication for gamma knife surgery. This is an example, small acoustic tumor, and this is the gamma knife. So I conclude my presentation. Brain tumor is a scary term. There's no doubt about it. But not all are malignant. For example, meningiomas and dermoids. Not all are benign, like glioblastomas. Nearly all malignant intracranial neoplasms will carry poor prognosis, just like other surgical branches. Example, glioblastoma. Not all benign would get cured, like craniopharyngiomas. The term biologically malignant, what I described in my initial 2-3 slides, biologically malignant seems most appropriate in neurosurgical world, where numerous pathological mass lesions, exact benign mass lesions, are located at dicey locations and which do not give any margins of oxygen to us in even millimeters. Henceforth, the best of neurosurgeon will be the best of thief, where he picks up the booty without letting any on-the-way object manipulate it, rather than a dacoit, where pathway obstacles are ransacked mercilessly. Thank you.
This was an excellent presentation.
Hari sir.
Learned something out of this presentation. For us, it was also very interesting. So, what about that Clinoidal meningioma? Do you do a control that might have stopped me? That was just a 20 So, we can say.
Anji sir. Yes sir.
जो Clinoidal meningioma, which is short carotid bifurcation in tumor.
I can't make out. Voice is not clear, sir. Hanji, sir.
Okay, I was asking
Hello?
that clinoidal meningioma, did you do a fronto-orthozygomatic osteopathy or it was a...
Yes, sir. Yes, sir. We routinely do, sir. Hello?
Got it.
Audible, sir?
Yeah, audible.
Yes, sir. We routinely do orbitozygomatic craniotomies for the skull-based meningiomas, anterior skull-based meningiomas. We routinely do orbitozygomatic depending upon the tumor's predisposition towards temporal or orbital region. Fronto-temporo-orbitozygomatic craniotomy is made at the skull base, and after that, CUSA is also used. Sir. We do not start these cases without full CUSA and drilling. Even extradural drilling of clinoid process, devascularization at the skull base is done. After that, the dura is opened up, and the meningioma is entered exactly at the skull base with CUSA to debulk.
Somebody wants to ask any question?
Yes, sir.
Thank you, Dr. Mitra, for an excellent presentation. And it was very enlightening for all of us here to listen to you and to see your wonderful, X-rays and CTs and MRIs, and also your videos which just showed how excellent work is being done, and it is possible. This has been done in our city also by Dr. Jen and Dr. Mills. But you have been very, very kind to take out time from your schedule and address us. So thank you very much on behalf of the Kanpur IMA CGP for sparing your time on this Sunday evening. And
Thank you, sir.
thank you once again. And thank you, Dr. Jayant and Dr. Amit, for organizing this session and getting such a good speaker for our audience. So thank you all once again. With this, we come on to the next session of the day. This is a session on nephrology. Again, we have Dr. Vivan, who has Vivan from Sargangaram Hospital in Delhi, who has joined us, and he would be talking on emergencies in renal disease and CKD. Another very, very important topic, and I think one of the right notes to end this week on CME. For this, I would invite Dr. Archana Bagore. She's among the senior most nephrologists of this city, and she's been doing a lot, not only for the patients of this city, but also for the IMA and for the CGP in general. She's also the past president of our organization in Kanpur. So I welcome Dr. Archana and hand over the session to lead our.
Thank you, Dr. Vasu. Welcome, Dr. Vivan. This is last talk, and will be followed by an introduction of this 38th IMA CGP.
Am I audible? I can't hear anybody here. Hello?
Hello, we can hear you now.
Yes, you can hear me now? Okay, I'm so sorry I couldn't hear the entire thing. But at the outset, I'd like to thank the Indian Medical Association and of general practitioners. And I'd like to thank Dr. Archana for having me here to speak on this topic, which is very close to both of us. This is emergencies in chronic kidney disease patients. So I'm going to run through these slides in a matter of about 30 minutes. And the kind of presentation that I've made over here is basically a case-based approach. I'm going to be talking about neurological complications, hemodynamic alterations, and complications of hemodynamics that we see in patients with chronic kidney disease. We're going to be talking about a little bit about metabolic disorders, acid-base disorders in chronic kidney disease. And in the end, I'll try to wind up with some complications in dialysis patients. And we all understand that this is a very, very vast topic, and I will try to do justice with whatever time that has been allotted to me in the next 30 to 35 minutes. And then we could take some questions at the end of the talk. So I begin my presentation with the first case. This is a 65-year-old male who's end-stage renal disease. He's on hemodialysis. He's brought to the emergency department with confusion, letharginess. He also has some myoclonic jerks in his extremities, primarily on his right upper limb and right lower limb. He has missed dialysis the previous week, and on examination, uh, the heart rate and rhythm are regular. He's breathing very comfortably. There is an irregular, subtle but excessive eyelid movement, which is more pronounced on the left side. Uh, and his limbs have mildly increased tone-based reflexes throughout with intermittent irregular myoclonic jerks. He has jerks in all the four extremities, though they are more noticeable on the right upper limb and lower limb. His plantar response is extensor, and when we look at his lab values, he has elevated serum urea nitrogen as well as serum creatinine levels. So with this, we come to discussion regarding what is wrong with this patient. This patient has myoclonic jerks, and he has preferential movement of one side of the body with tonic-clonic movement. So we think that this is a patient, and we are probably dealing with a seizure disorder. So the seizure disorder in chronic kidney disease patients is seen in up to 1/10 of these patients. And these are patients who could be not having a past history of a seizure disorder or any neurological abnormality, and still they could develop seizures. And 1/3 of patients with uremic encephalopathy will develop acute, symptomatic, and which is provoked seizure that you will see in patients who come to you in the emergency department. So the causes of seizure, when we are looking at a patient in the emergency department, we have to run through a couple of checks before we can actually diagnose the patient. The most important cause of a seizure disorder in a patient who comes to you with CKD in the emergency is malignant hypertension. So malignant hypertension is defined as a blood pressure which is higher than the recorded value of a normal value, approximately 100, 200 by 100 millimeters of mercury, having some kind of end organ damage, which you will notice when the patient comes to you. The second is ischemic stroke, intracerebral hemorrhage. Also, a condition called as a posterior reversible encephalopathy syndrome, which is secondary to either drugs or to uremia or even to accelerated hypertension. Electrolyte imbalances such as hypokalemia, hypocalcemia, and at times even hypomagnesemia can present with seizures. So it's prudent to send these investigations and to check the electrolytes in patients who come to you with altered behavior, altered sensorium in the emergency department. The foremost thing that has to be done when a patient comes is to check the blood pressure as well as to check the blood glucose and to rule out hypoglycemia, which is the most important reversible cause of a seizure. Apart from that, infective causes such as meningitis, which could be the tuberculous, fungal, bacterial. Also, osmotic demyelination syndrome, that's seen most commonly in patients who have been on diuretics and who've been hyponatremic and whose sodium levels have been corrected very rapidly. These patients can also present with a similar presentation. Advanced uremia, causing uremic toxins to play around with the brain hormones, can also cause altered sensorium and also lead to a neurotoxic state in which you can develop seizures. And the last but not the least is drug toxicity. So there are certain drugs which can interfere with the neurohormonal axis and also trigger a seizure disorder. So how do you treat a seizure disorder in a patient who comes to you in emergency? So the latest drugs that are on the line are brivaracetam. This is it's a very commonly used drug that we use nowadays, though it's not used for acute emergencies. It is used in patients who have been stabilized. For acute emergencies, we use drugs such as phenytoin, which seems to be still the drug of choice. Apart from that, we can also use levetiracetam, which can be loaded onto your patients, and also valproic acid. So bevacizumab does not require any dose adjustment, neither does carbamazepine, and you don't even need a supplemental dose after you do hemodialysis. But when you're using drugs like levetiracetam, you need to give at least half of the drug after finishing dialysis to maintain adequate levels in the blood. So phenytoin has to be given as a loading dose in most of the patients who do not have chronic kidney disease. But however, in chronic kidney disease patients, this loading dose is not preferentially given, though it is dependent on your individual practice, whether you want to give a loading dose or not. We go to the next case, which is a 55-year-old male. He's progressed to stage 5 CKD, and he presents to the emergency department with a chest pain, which is an anterior chest pain, and this worsens on inspiration. So you check this patient and you find that on the cardiovascular system examination, you pick up a rub at the pericardial area. And since he's CKD 5, you want to check his serum creatinine, and you find his serum creatinine is 9. Now, when I will ask you the differential diagnosis, it's not very difficult to diagnose what exactly is wrong with this patient. However, such kind of presentation has become an extreme rarity nowadays, considering the fact that most of the patients are now educated and they understand that they will develop complications of chronic kidney disease and initiate dialysis much before they develop this kind of an abnormality. So we're talking about uremic pericarditis or maybe pericardial effusion. So pericarditis in end-stage renal disease patients has been described as two entities. Either it could be uremic or it could be dialysis-related pericarditis. So in the uremic pericarditis has been traditionally described as the onset of clinical signs and symptoms before you initiate renal replacement therapy or within 8 weeks of its initiation. However, dialysis pericarditis has been defined as the occurrence of clinical manifestations after the patient has already been stabilized on some kind of a renal replacement therapy, whether it's hemodialysis or peritoneal dialysis for at least 8 weeks or more. So the diagnosis of a uremic pericarditis patient has to follow clinical as well as lab parameters. So in the clinical diagnosis, you have the Beck's triad, which is characterized by presence of hypotension, jugular venous distension, and muffled heart sounds. Most of these patients will complain of chest pain, though there will be patients that present to you without a chest pain, but you will have this muffling sound over the pericardium, which is a scratchy sound. Once you do the ECG, you find depressed PR segments and the diffuse ST segment elevation or the T wave flattening. What do you basically do when you have a patient with uremic pericarditis? So you assess clinically whether the patient has stable hemodynamics or whether he has unstable hemodynamics. So if he has stable hemodynamics, you would want to do intensive dialysis, and then reassess him. If you have resolution, it is solved. However, if you still have signs of tamponade, or you have an enlargement in the size of the pericardial effusion, or if the pericardial effusion appears to be unchanged, you would want to go in for pericardiotomy or pericardiectomy. Now, when you're looking at patients who are unstable hemodynamically, here we would not want to observe the patient because this is a life-threatening condition. You could end up losing the patient to a simple procedure that could save and be a life savior. And you go ahead and directly do a pericardiotomy or pericardiectomy, and also try to determine from the fluid that has been aspirated whether this is a uremic cause or is it an infective cause. So patients without tamponade would generally improve within 10 to 14 days of an intensive hemodialysis. But however, tamponade, as we understand from this chart over here, is an urgency and would require pericardiocentesis. We go to the third case. This is a 45-year-old gentleman who's been diabetic now since about 15 years. He has a compromised estimated GFR, which puts him into the stage of 4 chronic kidney disease. He is hypertensive since the past 10 years. His BMI is on the higher side, and he presents in the emergency department with severe headache, palpitations, and you notice that he has swelling in his feet. When you ask him and probe him, you also find out that he has orthopnea since the past 4 to 5 days. When you check his blood pressure, you find that his blood pressure is way above what is expected for a patient, which is 220 by 120 millimeters of mercury. At the same time, you will want to check his fundus. And when you check his fundus, you find changes of hypertension. So it's not difficult to know what exactly is wrong with this patient, but what is important is to know how to manage these kind of patients. So the most important problem that we find in patients of this sort is resistant hypertension. So resistant hypertension is defined as hypertension which requires at least 3 drugs, of which one is a diuretic for control of blood pressure. And the pathophysiology would include a variety of mechanisms such as an increase in vascular resistance, activations of the renin-angiotensin-aldosterone axis, and hyperparathyroidism. So we look at the specific symptoms as well as just generalized symptoms. The generalized symptoms such as chest pain, headache, blurred vision, dizziness, dyspnea, epigastric pain, polyuria, and very rarely gross hematuria because of renal infarcts. So specific symptoms which are related to end organ damage are such as chest pain, which is either myocardial ischemia, back pain, especially because of an aortic dissection, dyspnea, which could be due to either pulmonary edema or congestive heart failure, neurological symptoms, as we've discussed before, and we will be discussing some of them maybe later on, seizures, as we've told before, altered sensorium, which can be called as hypertensive encephalopathy. Apart from all of this, you should also be looking at other systemic illnesses when you're dealing with a patient who's presenting to you with either an accelerated hypertension, a malignant hypertension, a resistant hypertension, or refractory hypertension, which is essentially the use of at least 5 drugs for control of hypertension. You should be looking at systemic illnesses such as systemic lupus erythematosus, scleroderma, microangiopathic hemolytic anemia, and endocrine disorders such as Cushing's disease. You should also be looking at other spectrum of hypertensive crises such as catecholamine excess states such as pheochromocytomas, preeclampsia, scleroderma renal crisis, and also something called as a severe post-operative hypertension. How do we deal with this? There is a combination of drugs that can be used. The preferential drugs that could be used for resistant hypertension is a diuretic. So the diuretic could either be a thiazide diuretic or a loop diuretic, along with a combination of either a beta blocker, a calcium channel blocker, or an angiotensin receptor blocker, or an angiotensin inhibitor. So centrally acting alpha agonists appear to be one of the most commonly used drugs because they reduce the sympathetic renal outflow, and they are very commonly used because they give us very good control of hypertension. So as I've talked to you about, that diuretic therapy is what really helps in the end, because it reduces the volume expansion, improves left ventricular mass index, as well as the arterial stiffness. It also effectively reduces the mineralocatechoid receptor antagonists have recently become very, very popular with the use of eplerenone, which has been known to also slow down renal fibrosis apart from limiting cardiac fibrosis. However, it has its own share of side effects, which are very commonly seen, such as hyperkalemia, which is one of the commonest cause of morbidity in patients with chronic kidney disease. So the main pathogenic mechanism now in patients who are on dialysis, that is, you have progressed from CKD and gone up to dialysis, is a totally different pathomechanism here. So here, what is most important is the sympathetic nervous system appears to be overactive. So the use of sympathetolytic drugs would be more beneficial in these patients, followed by sodium and volume overload. So anything that causes excretion of sodium as well as excretion of excess fluid from the body will help you control the blood pressure, which is basically the diuretics. Also, an increased arterial stiffness is a common pathogenetic mechanism in which you will have arterial vasodilators, while vasodilators such as minoxidil, which are very, very useful. They cause relaxation of the arterial levels. And you also have activation of the renin-angiotensin aldosterone system, but the problem of using these drugs is recurrent hyperkalemia, endothelial dysfunction. These patients also have a high prevalence of sleep apnea, and correction of the sleep apnea could also help in improving response to pharmacological treatment. Most of these patients on dialysis also receive erythropoietins. Erythropoietins are hormones that are known to cause increase in hemoglobin concentration in patients with chronic kidney disease on dialysis, and they are also known to cause hypertension, especially those who have uncontrolled hypertension can develop resistant hypertension once they're put onto erythropoietin, which requires good drug control. We move to the next case. So this is a 72-year-old female. She has been chronic kidney disease patient since 5 years. And the last creatinine that her relative tells you is that of approximately 4 milligram per deciliter, which is about 5 years back. We don't have any records of this patient, on what drug she has been on, what is the kind of follow-up she's been having. But we do know that she has not been very careful with her prescriptions and with whatever advice was given to her. She also has hypertension, and we do not know what was the control of her hypertension. She presents to you with severe weakness, which is of 5 days duration. She's disoriented. Her attendants say that she was disoriented since the past 2 weeks. She also has been having severe nausea since the past 2 weeks. She has weight loss, which is significant to the extent of 6 kilograms in the past 3 months. She has pruritus since the past 4 months. And the serum creatinine is 21 milligrams per deciliter, which is way high for a 72-year-old female who doesn't have a very good body mass index and who has lost so much of body weight. So you go ahead, and because this patient has come with disorientation and weakness, so you want to check the neurological status, and you do a CT brain. On the CT brain, you do not find any infarct or hemorrhage. And so with this, we come to the topic called as a concept known as uremic encephalopathy. So encephalopathy is a very well-known entity, and it has a very broad coverage. If you don't understand why a patient is not responding to most of the therapies neurologically, then the term is encephalopathy. It occurs in patients with uremia due to buildup of uremic toxins, and it usually does occur when your creatinine clearance falls below 15 mils per minute. But we don't see most of our patients coming to us with uremic encephalopathy 15 mils per minute. It has to be lower and for a longer period of time. The manifestations could vary from mild symptoms such as asterixis, lassitude, generalized lassitude, fatigue, drowsiness, and there's a decreased ability to concentrate. Cognitive functions go down. There's a lot of confusion, and the patients are disoriented. This could also go and further on to severe symptoms such as seizures and coma. You can also attribute encephalopathy to acid-base abnormalities, preferentially metabolic acidosis, but metabolic alkalosis can also give rise to an encephalopathy, especially in the background of uremia. Hyponatremia is very commonly seen as a cause of encephalopathy, and a rapid correction of hyponatremia also can lead to encephalopathy. Hypocalcemia, which can precipitate a seizure and patient coming to you in a post-ictal confusion and could also be confused, could also be a cause of encephalopathy. Apart from that, septicemia, dehydration are other causes which could contribute in a patient with uremia to uremic encephalopathy. So when we are dealing with uremic encephalopathy, it's important to understand the pathophysiology. So for some reason, there is an increase in inflammation of the brain, and there's an increase in vascular permeability, leading to brain edema, neurological degeneration, as well as vascular inflammation. And there appears to be an imbalance between the excitatory as well as the inhibitory neurotransmitters. So what basically happens is that you have an increase in the level of glycine and a decrease in the level of GABA, and there's an accumulation of guanidino compounds, which leads to activation of the NMDA receptors, and it causes a further inhibition of the inhibitory GABA receptors. You also have an accumulation of false neurotransmitters such as methylguanidine, and this is postulated to be one of the mechanisms of uremic encephalopathy. So how do you diagnose uremic encephalopathy? Is by a simple test called as the electroencephalogram. If you can demonstrate on the electroencephalogram a disorganized wave pattern along with slowing and loss of alpha frequency waves with intermittent bursts of theta and delta waves with a slow background activity, you could call this an encephalopathy in the presence of uremia as an uremic encephalopathy. And how do we manage uremic encephalopathy in our patients? It's very simple. We just have to do a dialysis, and we have to maintain a particular curriculum of dialysis so that we do not cause the uremic load to suddenly shut down, and we go for very slow dialysis over or maybe every alternate day or maybe every single day, daily basis, short dialysis is done. And the most important thing is that you have to do the correction of electrolytes. That is, if somebody has got hypo or hypernatremia, has to be corrected. Hypocalcemia, hypomagnesemia has to be subsequently corrected. It's very rewarding to treat these patients, especially if they come to you in the early form, because it's rapidly reversible following initiation of dialysis. The next case is that of a 65-year-old male. He's a case of coronary artery disease. He's undergone an angioplasty about 4 years back. And he is stage 5 chronic kidney disease. He's not on dialysis. He's diabetic, he's hypertensive, both since the past 16 years. He gives you a past history of an acute myocardial infarction, which was about 5 years back. And 1 year following that, he had to undergo angioplasty. So he presents to you with worsening dyspnea along with orthopnea. The dyspnea has been worsening since the past 1 week, and he has progressed to orthopnea since the past 2 days. He's also noticed increase in his peripheral edema. So he already has peripheral edema, and so it has increased over the past 5 days. He's also noticed some cough with expectoration in the past 2 days, and his febrile since the past 2 days. So with this, we would discuss this patient, as we understand, is obviously in volume overload because he has symptoms of orthopnea, and probably the volume overload has been precipitated by some factor. And here it appears to be a fever and cough, which could be an underlying consolidation in the lung. And he has all the risk factors like diabetes, hypertension, advanced chronic kidney disease, and probably he also has some amount of cardiomyopathy because of a past history of coronary artery disease. So volume overload is one of the most important cause of increased morbidity and mortality in patients with chronic kidney disease. It frequently manifests in patients with moderate, and particularly in patients who have progressed to almost the last stage of chronic kidney disease. And it is consistently associated with hypertension, congestive heart failure, left ventricular hypertrophy, stiffness of the arterioles, as well as edema. On this pictorial, I've tried to demonstrate that this is a situation in which you have a crosstalk between the kidney and the heart, and both the kidney and the heart in the crosstalk do not want to come to any kind of a conclusion. So if you have an increase in the afterload, that is, you have a volume overload, there's an activation of the arterial baroreceptors, which would cause a non-osmotic vasopressor stimulation, causing renal water retention, as well as an increase in peripheral arterial resistance. There will also be stimulation of the sympathetic nervous system, and all of this will contribute to reduction in renal sodium and water excretion, as well as edema. So once you have the stimulation of the sympathetic nervous system, the loop again goes and causes activation from the activating factors such as the brain natriuretic peptide, as well as the atrial natriuretic peptide, to again start the same loop and cause something called as a cardiorenal syndrome, which is now a very well-known entity in which you have the cardiac as well as the renal failure, causing failure of each other progressively. So how will you assess a patient with volume overload? It requires both the clinical assessment as well as the lab assessment. So in terms of clinical assessment, and in lab assessment, the most important lab assessment over here appears to be the use of bioimpedance analysis, which is body water estimation, as well as the use something called as the POCUS. The POCUS is it's a very latest technology which uses ultrasound to determine curly B lines on a bedside examination, and you can actually find out the volume status of the patient, whether it's overloaded or underloaded, because there are patients who might not have peripheral edema but may have some amount of volume overload status, irrespective of the presence of pulmonary edema. But generally, you're looking at dyspnea, progressive increase in weight of the patient, and you have to also take a history of excessive salt and water intake, either in the present or in the recent past, because patients who have not been compliant to salt and water intake would never be compliant ever. So when you examine these patients, you will have the jugular veins which are elevated, they are full, as well as you will have rales or crackles. When you auscultate, they will have pedal edema. So investigations that are commonly used, I said, one was POCUS. The second would be to use the inferior vena cava measurements, where you would essentially use the echocardiographic probe to determine what is the collapsibility index of the IVC in response to respiration. So if there is no variation in response to respiration, we feel that at that time the patient is overloaded in the system. Apart from that, some of the centers would also like to perform an NT-proBNP, though it does have some limitation in patients with chronic kidney disease, and it's difficult to actually formulate a diagnosis of volume overload because NT-proBNP is falsely elevated in patients who are not volume overloaded and who have chronic kidney disease stage 2 and beyond. Some centers would also like to evaluate the brain natriuretic peptide, though we don't do that. And we do find bioimpedance analysis a very important tool, especially in patients who have been on dialysis, to determine the dry weight. And this is the weight with the least amount of water in the body, and which will ensure that these patients do not go into pulmonary edema again and again. Apart from that, POCUS is also can be used for not just determining the curly B lines, but also to also determine the extravascular lung water, which is a very easy bedside investigation that can be done. So how would you treat fluid overload? First and foremost is to reduce the salt intake, without which you will never be able to treat these patients. Second is very intensive water restriction. Third would be the first choice diuretic is a loop diuretic, especially in patients who have a GFR of less than 30. You can also combine a loop diuretic with a thiazide diuretic, especially in GFR of more than 30 mils per minute. So, but we have to understand that whenever you use a diuretic and whenever you use them in high doses, it's going to cause a compromise on your renal function and cause decline in your GFR, as well as cause metabolic complications, electrolyte imbalances, as well as acid-base disturbances, especially metabolic alkalosis. And when nothing else really works, then you have renal replacement therapy in the form of either a scuff, which is just isolated ultrafiltration, or in the form of hemodialysis if the patient has a compromised GFR along with requirement for strict ultrafiltration. With this, I come to the next case, which is a 31-year-old female. She's a known case of lupus nephritis. And she has stage 4 CKD, she has hypertension, and she has anemia. She has been on steroids since the past 5 years, as well as she has been initiated on diuretics for peripheral edema in the past 6 months. She presents to the emergency department with weakness in all the 4 limbs of 2 days duration. She is constipated since the past 5 days, and she has palpitations since the past 1 day. So on evaluation, you do an ECG, and the resident tells you that the patient has tall T waves with prolonged PR interval, which gives away the diagnosis. And when you ask her that what she has been eating, because you want to know why she has been having this kind of presentation, she tells you that she has been only on fruits and soups since the past 10 days. So we are dealing over here, obviously, with something called as hyperkalemia, not very difficult to understand here. So it is defined as a plasma potassium level of more than 5.5 millicrons per liter. So patients who present to you with hyperkalemia are generally asymptomatic. They have non-specific symptoms, which could be related to either muscular or cardiac function. And the most common, however, in the departments is the presence of weakness and fatigue, as in our patient. And sometimes they could just come with just frank paralysis, shortness of breath. Arrhythmias is one of the commonest presentations in these asymptomatic patients. When you do ECG, you find either a sinus bradycardia or an arrest, or they could have ventricular tachycardia, ventricular fibrillation, and a fatal asystole too. Once you have a patient with hyperkalemia in the emergency, apart from handling the case, which we will see later on, we have to understand why this patient was hyperkalemic. So we need to find what the drugs that these patients have been on, whether they've been on NSAIDs, whether they've been beta blockers, which cause direct inhibition of the renin, or ACE inhibitors, which cause inhibition of the ACE enzyme, or angiotensin receptor blockers, which act on the angiotensin 2 receptors. Apart from that, diuretics such as spironolactone, eplerenone, which is very commonly used in the cardiac units because they are very popular drugs, considering their safety data that in cardiovascular, advanced cardiovascular disease, and their good role on LV remodeling, as well as renal fibrosis prevention. And also on the tubules, there are drugs such as amiloride, trimethoprim, which cause decreased excretion of potassium from the tubules, causing the presence in the blood. So depending on the kind of ECG that you have, you can actually find out what is the level of potassium in your patient. Our patient had tall T waves and he had prolonged PR interval. So probably anything between 5.5 to 6.5 would have been the potassium in these patients. And once it becomes more than 8, you have P waves which are absent and a sine wave pattern, along with progressive widening of the QRS complex, along with some kind of bundle branch blocks. And most of these patients will end up in the cardiac unit for pacings. The treatment is, the most important treatment to start is using a membrane stabilizer, which has an immediate onset and immediate effect lasting for up to an hour. So this is the use of injection calcium gluconate, which can be given as a 10 ml, 10% solution, and 1000 milligrams can be just infused straight away over 2 to 3 minutes time. Along with this, we use a combination of insulin plus glucose, which potentiates the effect of the membrane stabilizers in the form of 10 units of regular insulin with about 50 ml of 50% dextrose. And this lasts for approximately 4 to 6 hours. Once you're given these two drugs, you can also put them onto nebulization with salsol, which is salbutamol, which also acts within about 30 to 45 minutes, and give a shot of furosemide. So furosemide is also known to cause excretion of potassium through the tubules. Sodium bicarbonate is used to negate the metabolic acidosis, which is known to cause extravasation of potassium into the blood and drive potassium back into the blood, back into the cells. This is the similar mechanism which is used by insulin plus glucose, which drives the extracellular into the intracellular. And to maintain a good low potassium level, it's always good to use something called as K-bind, which is sodium polystyrene sulfonate. So these are basically binders, and they can be used from 1 packet to about 4 packets a day. However, their onset of action is prolonged, that is beyond 2 to 3 hours. It stays for about 6 hours. And when nothing else works, or the patient has ECG pattern which shows that this is severe hyperkalemia and will not give you time for the use of either a membrane stabilizer, or somebody who has refractory hyperkalemia, despite giving all of this therapy, you find that the potassium is bouncing back again to high levels with ECG changes, then it's definitive to do a hemodialysis. So this is a little bit about the potassium binding agents. We do not have sodium zirconium cyclosilicate or patrimer available in this country, but they are going to be introduced very soon. And as I've talked to you about before, that it can be used as a rectal enema also, apart from being used as an oral suspension. It has its own problems such as constipation, which is quite severe in our patients, metabolic alkalosis, hypokalemia, hypomagnesemia, and hypocalcemia. The most important adverse reaction is the presence of is colonic necrosis. So once you once you do the dialysis, then what are we looking at? We are looking at something which removes potassium at a very high rate, and it removes about 15% of potassium is removed in the first hour with the ultrafiltration, and over the next few hours, that is up to 3 to 4 hours, about 40 to 120 millimoles is removed. This goes against peritoneal dialysis, which is actually a very slow form of removal. So hemodialysis is for acute emergencies, can remove potassium, and peritoneal dialysis takes a little longer time, in fact, a much longer time as compared to hemodialysis, and is not the preferred mode for removal of potassium in patients with refractory hyperkalemia. So the mechanism of using peritoneal dialysis is to do rapid exchanges so that you can equilibrate the peritoneal capillary potassium with the potassium levels in the peritoneal dialysate, and remove that at rapid pace every half-hourly cycles. So to end, I would like to just talk a little bit brief about emergencies in hemodialysis. This is a very big topic in its own. So the most important is the central venous catheter related complication. This is something which is seen very commonly in the form of the first is initially is the placement of the central venous catheters. These are those necklines that you see in our patients. We could have pneumothorax, hemothorax during the placement, or even a couple of days after the placement of these catheters. But the most important cause and the most important complication still appears to be infections which are related to these catheters. Apart from that, when the patient is getting dialyzed, they could develop dialyzer reactions, type A, type B reactions, which are fatal sometimes when they're not recognized. In patients who have been recently initiated on dialysis and do not follow a dialysis prescription from a nephrologist, could also end up in something called as a dialysis disequilibrium syndrome, which is basically condition in which a patient has encephalopathy secondary to brain edema because of very rapid removal of uremic toxins from the blood. Then there are some technical errors such as hemolysis, blood loss, a problem with the conductivity in the machine, which can give rise to either excessive hypertension or could give rise to hypotension, and also related to the temperature of the dialysate fluid, you could have the blood pressures either going up or going down. Air embolism is something which is not very commonly seen in today's world. However, it should be one of the diagnoses in patients who have had a very recent placement of a central venous catheter, and this is seen. Hypotension is the most common cause of rushing to the emergency department in hemodialysis. So most of the calls that a nephrologist would get from the hemodialysis unit would be because of hypotension. There are several causes of hypotension, which could be either because of patient factors, such as presence of cardiovascular disease, use of some kind of drug that causes hypotension, or even feeding during dialysis can give rise to hypotension. It could also be because of a cardiovascular event that the patient has had either before dialysis, during dialysis, or it could be because of machine-related factors, such as excessive ultrafiltration or the use of low temperature dialysates, high temperature dialysates, and also because of sepsis most commonly. That is, if you have a dialyzer reuse program and the reused dialyzer has not been sterilized properly, then you could be introducing sepsis and causing hypotension. Apart from that, hypotension could also be caused because of excessive blood loss or excessive blood clotting into the membrane or the filter of the dialysis circuit, which could also be responsible for this kind of a presentation. So with this, I'd like to end over here, and I would thank you all for your patient listening. I'm open and I would like to take questions if there are any.
And it actually covers all the conditions which emergency medical officer encounters during his duty. The take-home message for the physician friends would be that when they are treating the diabetic patients, the diabetes has to be controlled, and when the GFR falls from oral hypoglycemic drugs, they should switch over to insulin to avoid hypoglycemia. Hypertensive medications have to be taken properly, and because they will end up into hypertensive emergencies. Volume status has to be managed, and whenever the physician suggests for dialysis, the patient should go in for dialysis and not go in for, say, any alternative treatment, because you know what the alternative therapy does is that they decrease the food intake, they decrease the protein intake of the patient, and that is how falsely the serum creatinine comes down. But in fact, the patient is deteriorating, and then he presents in the ER with all the complications which you have accumulated: acidosis, hyperkalemia, fluid overload, accelerated hypertension, etc. So this is the take-home message which you have very clearly told in your lecture. One incident, Dr. Vinod, which I want to share with you is that when I was a resident at Sankalram Hospital, one patient was on dialysis, and when Dr. A.K. Bhalla came on the round, that patient insisted that he should be allowed one fluid. So Dr. Bhalla, as usual, was in a hurry. He said, okay, take one fluid. Then in the night, when I was on duty, his gentleman came back in the emergency room with gross fluid overload, pulmonary edema, hypertension, very severe metabolic acidosis. So I asked him, what happened? You were dialyzed today. His wife said that you told him to take one fruit. He bought the biggest watermelon which he could find in the market. And he said, I'm eating one fruit and I finished this fruit because I've been permitted by the law. So volume status has to be taken care of and patients have to come back. Thank you so much for the very nice talk which you did. Thank you so much.
Thank you very much.
It was a pleasure listening to you. And since we are just exceeding our time, so I think we'll take questions. Maybe we'll pass them on to you and get answers to that. So on behalf of the IMA CGP, it's thank you for spending your time on this Sunday evening. and addressing us on such an important topic. It was wonderful to listen to you. And I also thank Dr. Archana for having arranged this talk and motivated to this platform. So thank you all. And we now move on to the final presentation of this CGP. It has been a week-long festival of academics where we had wonderful lectures and wonderful interactions, a great many positive things to learn and a great many experiences to share. And that's how we have been having a wonderful journey for the last year. Finally, today we have a Vestibular and esteemed surgeon of the city. I think I will ask the chairperson of the evening, Dr. U.C. Sinha, who is the president of the State Kanpur Surgical Club, the senior surgeon of the city, Dr. Deepak Agarwal, who is honorary secretary of Kanpur Surgical Club, and again a very senior surgeon in Kanpur, Dr. Shwanshu Mishra, an upcoming bariatric surgeon of Kanpur. And I will ask them to introduce Dr. S. Mishra. The city of Kanpur does not need any introduction for Dr. Mishra, but there are audiences beyond our city also because of this national conference. So I will ask Dr. Deepak to please take over the session.
Thank you, Dr. Vargas, for handing over the session to me. Dr. Shivakant Mishra does not need any introduction, I think. He is a role model for many of the surgeons of this part of the world. He is a senior consultant laparoscopic and obesity general surgeon. Currently, he is the director and CEO of Shivani Hospital in IMA CGP Kanpur. He is a member of Central Council of Health and Family Welfare, Government of India. Currently, he is also heading the post of Vice President, National Board of Examination. He is an honorary professor of Indian Medical Association, also honorary professor of Indian Medical Association, Academy of Medical Specialties. He had been past president of SARC Surgical Care Society 2018 and 19. He had been president of Association of Surgeons of India, which is the largest body of surgeons in India, 2017. He has been the president of Indian Medical Association of Kanpur, the centenary year of 2012. He has been awarded Doctor of the Year 2017, also awarded Lifetime Achievement Award by the Association of Surgeons of India, and Sardar Vallabhbhai Patel, the National Award by Government of India. Today, Dr. Shivakant Mishra will be talking about miracles of minimal invasive surgery. It itself is a very vast topic and covers the horizons of the minimal invasive surgery, which now has evolved in every field of surgery, from general surgery to urology, gynecology, metabolic surgeries. Dr. Mishra will be talking a glimpse of whatever has been or is being done in the world in the field of minimal invasive surgery. Professor Shivakant Mishra.
Thank you, Dr. Deepak, for kind introduction, and I bring greetings to all of you, especially my chairpersons, Dr. U.C. Sinha, Dr. Shwanshu Mishra, and all the audiences. Let me thank the IMA CGP Assistant Director, Dr. Ravi Kumar, and Secretary, Dr. Bajwa, for inviting me for this talk. This talk, basically, I'm a surgeon and I'll be talking about minimally invasive surgery. MIS is minimally invasive surgery, but I'm not going to talk about intricacies of the surgery, but it is meant for practicing physicians to know the horizons and what MIS has done to the modern surgical practice. And everybody must know that there has been a sea change, the way surgery has been performed in last few decades, especially when it came towards the end of the 20th century. Few decades saw the invent of minimally invasive surgery, which actually was confined to few procedures like gallbladder surgery, appendix surgery. Later on, things grow exponentially to cover, I think, not only the abdomen, but I would say whole human body, whether it is brain surgery or it is a thyroid surgery, or you do a surgery in thorax, or there is orthopedic surgeons, urologists, gynecologists. Everyone has been using minimally invasive surgery to the advantage of the patients. Next. Yes. Okay. So if we talk about the miracles in the surgery, we know that in the history of the surgery, there have been so many miraculous surgeries performed, like the removal of half of the child's brain, or there has been in the history 4 days continuous operation at Chicago. There has been surgery in utero when there was abnormality within the fetus, that was operated through tiny scopes. And there has been surgeons who have been performing surgery on themselves. You will be surprised to know that even a surgeon performed his own appendectomy under local anesthesia using mirrors. And also the surgeries for cases like von Recklinghausen's disease, where the face is so much distorted, it's a neurofibromatosis, which has been operated successfully. Or there was again a miraculous surgery in the form of, like, once pregnancy is there, a 22, 24 weeks pregnancy, a sacrococcygeal tumor was diagnosed, and the surgeons, they operated, they opened the uterus, they delivered the baby partially, and they performed the surgery, again repositioned the fetus inside the uterus, closed the uterus, and then the final delivery or final opening up of the uterus took place after 20 weeks or so. So that kind of surgeries have been reported in the literature. But what the minimally invasive surgery has done, tooth surgery, it is really, I would say, every procedure is a miracle. Miracle for the patient, miracle for the surgeon. It is also known as scarless or stitchless surgery or keyhole surgery. And if we are confined to the abdomen, it's a laparoscopic surgery. It is the marriage of the modern technology and surgical innovations. And as we know that we do a procedure which is performed through tiny incisions instead of a large opening, because your surgeon will make a smaller incision, you are likely to have lesser pain and quick recovery. And that is what we are aiming for any surgery. Aims of the minimally invasive surgery are to minimize somatic trauma, minimize psychological trauma, to reduce the hospital stay, as well as faster recovery or recuperation. So as I have mentioned, if we do in the abdomen, laparoscopy, these are categories: thoracoscopy, endoluminal endoscopy, perivisceral endoscopy, arthroscopy, intra-articular surgery, and the combined approaches. There are many, I think, more procedures. Wherever you use inside the nostril, if you are using whatever cavity that is named after that. Basically, for our physician colleagues who have not been to the operation theater, just to show that how we approach abdomen, rather than giving a long incision, we put we make tiny holes and we put small trocars, and through that we put hand instruments, we put telescope which is fitted with a camera on the top and light source, and we visualize the picture on a monitor. Now the science has advanced so much that we get so much beautiful definition and picture quality, which is much superior to what we see through the naked eyes. That is why minimally invasive surgery is getting safer and better, because we see many times magnification, many times better clarity. We can see even smaller lymphatics. So that is the beauty. And because of the smaller incisions or smaller cut we make, we have got advantages: less pain, less scar, less chances of infection, lesser hospital stay, quick recovery time, less scarring, and reduced blood loss. There are certain disadvantages, and as I would say that many old timers, they found it a difficult art to learn. It was a new technique, and if you don't master it well, if you don't train yourself well, if your learning is not good, then certainly it is not going to help. So these are limited, but I have seen so many senior surgeons taking up this art, and they have been the wonderful MIS surgeons. Now, coming to the common surgery, like gallbladder, we started this MIS with the gallbladder surgery. And as you can see, it's a very cirrhotic liver. Initially, we used to have a lot of contraindications for doing even gallbladder surgery. But today I can say that except for malignancy, we operate everything, all kind of gallbladders by laparoscope, and we give all the advantages. So this is the gold standard surgery. Now, if we go ahead, we even explore CBD, though the gold standard treatment remains that if there is a gallbladder CBD stone, you subject the patient for ERCP removal followed by laparoscopic cholecystectomy. But there are instances where the ERCP treatment fails, then you don't have any other option but to either do an open exploration or a laparoscopic exploration. Here, this case I'm just showing is an 88 years old lady where such big stones are being removed. I think twice the attempts to remove the stones by endoscopy or ERCP have failed. Laparoscopy scores over it, and not only you remove all the stones and you visualize inside of the CBD beautifully through the cholecystoscope. And this is a one-stage procedure. You perform CBD exploration along with the cholecystectomy. So patient is also not subjected to multiple procedures. So this is the advantage. So this is all being done by MIS here in our own city. Then coming to the another common operation, which I would say now it's not so as common as we used to do in our medical college days, but this is a beautiful operation. Again, very many surgeons have been telling that they can do the appendicectomy through a tiny hole or a small incision. But let me tell you, not all kind of appendixes can be dealt with the tiny incision, especially the retrocecal, high retrocecal appendices, and they are highly inflamed, thick. Then we need to have approach. And one most important thing which I would like to remind to our physician colleagues, that in young females, about 40% of the patients presenting with right iliac fossa pain may not be having appendix, but some other gynecological problem. The laparoscopy gives an advantage of doing diagnosis and a definitive diagnosis and then a treatment. It is very important. Then coming to hernia surgery, endoscopic treatment of hernia has been controversial, and because the hernia surgery, open hernia surgery is supposed to be a basic surgery, which I think every surgeon, every general surgeon knows how to deal with that. But once it comes to the laparoscopic or endoscopic repair, hernia, which could be TAPP, transabdominal preperitoneal, or TEP, depending upon the choice of the surgeon. So in these cases, one has to be little smart advanced laparoscopic surgeon, because here you deal with a different kind of anatomy which we don't see in a conventional open surgery. But believe me, the advantage it confers to the patient that you can do a bilateral repair at one time, you can deal with the bigger hernias with your expertise, and the recovery is much, much faster. The only thing is, it is always done under general anesthesia. And as I have mentioned in the slide, that there are as many techniques of hernia as there are surgeons. So everybody has got their choice. But if you talk about the patient comfort, so certainly the laparoscopic technique or the minimally invasive technique offers much better advantage. It scores over the conventional hernias. Then coming to the ventral hernias or incisional hernias, we are seeing many, and it could be debatable what could be the reason for a incisional hernia, whether it is because of tissue problem or there is a faulty surgical technique of closure of the abdomen. But ultimately, we see a lot of incisional hernias, as well as we see with a growing obesity, lot of umbilical hernias, paraumbilical hernias, and this I would say the IPOM, laparoscopic intraperitoneal Ole mess, is a gold standard treatment for such kind of hernias. Here again, there is a tiny incision, minimum scar, and there is a minimal chance of wound infection or the mesh infection, and the recovery is very fast. So this is a preferred technique by many, and especially if the recurrence occurs after the open repair, or if the infection occurs. And I've seen patients suffering a lot and maybe presenting with adhesion, obstruction, etc. So this can be dealt with laparoscopically beautifully. Next is, we see the diaphragmatic hernias. Now, all the senior physicians, they all know, even surgeons, that previously we used to do all these surgeries by open technique, long incisions, and lot of morbidity to the patient. But now, with the minimally invasive technique, with the advanced imaging system, it has become such a wonderful surgery that you can see this a young boy who presented to us with a Bogdalek hernia, and all the bowel, everything was there inside the left chest, and one has to reduce gently all the contents. Of course, it is done under general anesthesia, and once you have reduced everything to the abdomen, you just go and inspect the cavity where it was lying, and you will see in a meanwhile that how much bowel, the large and small bowel, was occupying the pleural space, and you can very well see the lungs, collapsed lungs, they are lying there. So this opening, you have to refashion and to close this opening with the non-absorbable sutures, and then you have to reinforce this weak point with a dual mesh. So this is all possible through minimally invasive technique, only using 2-3 tiny holes, small cuts, and whole surgery is completed. So this is the beauty or advantage, and how the patient get benefit of minimally invasive surgery, and they can be discharged on 3rd or 4th postoperative day. Of course, a chest tube is being put, and once the lung is expanded, you take X-ray chest, and then you can discharge the patient on very, very fast, very quick recovery. See, another problem which we are increasingly seeing is the GERD, the gastroesophageal reflux disease. Anti-reflux surgery is sometimes indicated. I would say there are good PPIs and other medical management, but lifestyle changes, drug therapy, and ultimately there are many patients who have been on PPIs for years and they have got lot of distressing reflux symptoms. They get advantages of minimally invasive this Nisin fundoplication, which gives excellent result. And in the West, it is very common procedure being performed. And here in our places also, we are doing it regularly where the esophagus is mobilized. So to bring around 4 to 5 centimeter inside the abdomen, all the adhesions are released and the gastroesophageal junction is quite clearly defined. And once the fundus is also lysed of the short gastric vessels, and the sleeve or the collar of the fundus is wrapped around the lower esophagus to create a valve. So this is a beautiful procedure, and magnification you can see, and the legs, there's a crurorrhaphy is being done so that large hiatus is reduced to a normal minimum one. So there are 2-3 sutures, they are done, and shoe sign maneuver and to wrap the fundus. So this is how we deal without giving large incision. That is the advantage. And you can see mostly the patients are obese and patients are having comorbidities. You can very well imagine the such surgery, if you do by open technique, how much problem they are going to. And this is quite easily done and frequently and routinely done at our places. Now, we often see, in our part of the world, we see a lot of hypertrophic ileocecal tuberculosis requiring hemicolectomy. We also see cases of right colon, and this procedure initially used to be done by open technique only, but we can offer to our patients advantage of minimally invasive surgery, and we deal and mobilize the colon. We deal with the ileocolic and the right colic and the right branch of the middle colic through the laparoscope, and we mobilize whole of the colon accordingly. Then we can do resection anastomosis outside by giving a small incision, that would be hybrid technique, or we can do total laparoscopic hemicolectomy. So similarly, for other cancers like carcinoma rectum and sigmoid, all the procedures are available. Even for rectal prolapse, we do the rectal prolapse operation, all through the minimally invasive technique. So this is how all these demonstrations are there because our physician colleagues, they hardly get any time to go and watch, and at least they can themselves watch and see how these procedures are being done. And if the patient comes in emergency with a severe abdominal pain and shock, especially in a childbearing female, one should suspect of ectopic pregnancy, and which again I would say can be dealt beautifully by laparoscopy or by minimally invasive technique. And here, a word of caution, I would say, for in most of the cases, the gynecologists, they do a laparotomy and they do a self-injectomy or removal of the ectopic. But I would say as a surgeon, more you open, more chances of adhesions are there. See, if you can see very well a small fetus, you can very well do by minimally invasive technique, and that will prevent or that will minimize adhesions. And especially the females, they want another child. So it would be helpful if we do with a minimal invasive technique. We also deal with the situations like acute intestinal obstruction. Of course, short history cases we always take for laparoscopy, and we may find band or a small adhesion or a small volvulus, which can be dealt with. Of course, one needs to have expertise to put a scope in the distended abdomen, but carefully you can achieve that. And one can save a lot of morbidity of having a patient staying after laparotomy for longer period of time and staying for a longer period beyond the work. So one should be applying the minimally invasive surgery as much as possible. Is one piece of advice for my physician colleagues: when the patient comes with a chronic abdominal pain, we often advise ultrasound, then maybe CT scan, MRI, and whatnot. But still, the patient keeps on coming or keeps on changing the doctors. I would always say the laparoscopic diagnosis is something which will save you from so much of embarrassment. And one may find adhesion or stricture or other problems which could be the cause for chronic pain. So always laparoscopic diagnosis is something one should always keep in their armamentarium. Finally, coming to the, I would say, real miraculous thing is obesity and metabolic surgery. I'm sorry to admit that most of our physicians, they are scaring the people, scaring the patients that, oh, this metabolic surgery or bariatric surgery is dangerous. It has got a lot of complications, and patient after getting this surgery will be, I think, will not be able to eat anything, etc., etc. But let me tell you that it is as safe and as practical as a gallbladder surgery. It has got no, provided you investigate the patient well, you counsel the patient well, your preparation, optimization of the patient has to be good selection, and then there are variety of procedures. The procedure fails or complications occur if you have applied a wrong procedure to wrong patient or you are not sufficiently trained for it. Otherwise, it gives a miraculous result in, I would say, all the cases, and one should take advantage and one should apply or advise metabolic surgery and obesity surgery to their patients. Apart from sleep, one can do the MGB or mini gastric bypass or even Roux-en-Y gastric bypass, which all have to be done, and they should be in the armamentarium of a good bariatric surgeon. So these procedures, they give instant relief or instant cure to so many comorbidities, including diabetes, hypertension, dyslipidemia, osteoarthritis, in PCOS, and obstructive sleep apnea. All these things, I would say, they get. So what else you expect? And that is what this is, what you have to offer to your patients. And this is how the procedures are performed beautifully, and they are mechanized device. And because of these staplers and other disposables, the cost of the surgery may be little high, but nothing as compared to the treatment of so many comorbidities. See, even if you go for a bypass surgery or a knee replacement, etc., they all cost. So comparative to that, they are very, very cost effective and economical surgery. I'm not going to detail because I have to finish it up. Now, sorry, you can see so many patients benefited by this bariatric or metabolic surgery, and you can see it's not only the appearance, it's not a cosmetic surgery, it cures comorbidities. So one should be utilizing all these things for their patients. Even urology for removal of large Staghorn calculi, or for that matter, this ureteric stone, they are all being done through the laparoscope, very I would through minimally invasive procedure, and patient is always benefited, because here, unlike open technique, of course, nowadays stones are dealt with by PCNL, lithotripsy, very few, I would say, by open technique. But in old time, we used to do open, where 12th rib cutting and all those things was. Now it is all redundant. You approach the pelvis. See, you can see the pelvis, you can see the stone through it, and you approach directly, and that is how you deal with whether it is kidney stone. And see, just holding with a grasper, you take it out, and then after that you put a DJ stent also. I'll just show you how this is being done. Now this big stone has been removed, and a DJ stent is put laparoscopically only. So this is how you give advantage to your patient, and the patient also remains comfortable, so they are not scared. So that is what is the beauty of MIS. So this is the stent being put. And now quickly coming to my, I think, last video, that is about the ureteric stone. It takes 10 to 15 minutes only to, 10 to 15 minutes only to remove any big stone, because just you go in the retroperitoneal space, and you see the bulge, and you give an incision, and you remove the stone. You can see the urine coming out, and how this is opening is bit dilated, and this stone is being removed. So this is the advantage. All the, I think, specialties and subspecialties are using it. And now we have started in the national board this minimally invasive urology as well, which will be now a fellowship course. Of course, post-doctoral means MCH or DRNB people will be able to join that. So this is about minimally invasive procedures. So essential is, to conclude my slide, this: you need to have a dedicated training, proper case selection. You need to have best equipment. This I always emphasize, that if you want to be successful as a minimal access surgeon, then you should have best of the equipments. So rather buying a good car, you should buy a good system, and that will really help you, and that will give a best result. Good monitoring, and you have to be cost effective. If you are expensive, then naturally it would not be your choice. And people should be aware to utilize such services. Actually, today's lecture I have kept to make our colleagues, physician colleagues, aware about the options available. And this is our team. Thank you very much for a patient hearing. And I again congratulate the IMA CGP team for organizing this wonderful show, which used to be a festival like every year, but because of COVID phenomena, this is happening for the first time in a virtual way, and they have done a lot of hard work, and it's being done in our beautiful, newly constructed medical conference room, which is equipped with the Cisco WebEx system, and who all are there, they can appreciate the beauty of this modern conference hall. Thank you so much. Any question? I am ready to answer. Otherwise, I think validatory function is about to begin. So thank you very much, chairpersons. Are you there if you want to ask anything? voice question को repeat करेंगे? Can you repeat the question? I couldn't hear.
We are not taking questions because this is an oration.
Yes, yes. Thank you very much. Thank you.
Thank you, Dr. S.K. Mishra. It is the very perfect timing also for the completion of this 38th differential course of IMA CGP, because awareness is very important and proper knowledge is also very important. Awareness amongst general physician is also very important. There are so many misconceptions they are missed regarding minimal invasive surgeries, and we have very nicely, very elaborately, and we have shown also what can be done with the minimal invasive surgeries. There are a lot of things can be done. You are very rightly told. The most important thing we were told in the initial days of surgery, learning that the two most important factors are you have to see properly, good exposure, and you have to honor the tissue, minimum tissue damage. These are the two factors. And this minimal invasive surgeries, it completes both the factors. There's a very nice exposure, magnified exposure. You can watch the small vessels, even the lymph nodes also, if you know how to see, and definitely the tissue damage, minimal tissue damage. These two things has created a lot of miracles. Now we can do so many surgeries from the abdomen to thorax to neck. From here, I think from everywhere we can go with this minimal invasive surgery, and we need to be aware what can be done. Thank you, Dr. Skinson. You have very nice.
Thank you very much. And I would like to take opportunity to thank.
We used to not to South or Delhi or some other places for such advanced laparoscopic surgery, but now I'm very happy. We all are very happy that we have got a center and so many advanced laparoscopic surgeons. We have got, and we are performing so many nice surgeries, and I'm happy also that Dr. Shivansu is here. He's performing very nicely. There are so many other young surgeons. They have come. They are performing very nicely. The advanced laparoscopic surgery being done at Kanpur. Need not to go to other places. All can be done at Kanpur. And for that, Dr. Shivansu, we are proud of you, Shivansu. And I'd like to have few words from you also, Dr. Shivansu.
Thank you, sir. My father, my mentor, and seniors, veterans, Deepak sir, Sinha sir, and for giving this opportunity, and all the IMA fraternity sirs. Thank you all for giving this opportunity on this August occasion. And especially my father, I have always seen him as a mentor, and he's always taught me what is the difference between a good surgeon and a great surgeon. Good surgeon may operate on many aspects, but a great surgeon would know when not to operate. So what I have learned from him, and of course the seniors of this Kanpur Surgical Club and my mentors in South, Dr. Palani sir, that everything, be it open surgery or laparoscopic, minimally invasive surgery, be it laparoscopic or robotic, the surgical principles remain undisturbed, and we always have to respect the plates, the tissues, and there are always indications and certain indications of minimally invasive surgery have narrowed down, and there have been exponential with the growth of laparoscopic surgeries. But again, we all have to know the limitations with laparoscopic surgery, and with certain, when the patient proper consent and proper knowledge of the patient, we have to proceed. Thank you once again, Papa, and thank you once and all for this time. Thank you so much.
Thank you. I would like to thank my colleagues, not only from Kanpur, but from various parts of the country. I can see quite a few of my friends who have joined me, and also beyond the country. I am thankful to all of you. Thank you so much.
Thank you very much. Thank you, IMA CGP.